Welcome to our video history. Our person for interview today is Dr. John Queenan. Dr. Queenan, thank you very much for coming to be interviewed and tell us a little bit about your history. Today we're going to start very early. Where were you born?
I was born in Aurora, Illinois, a town slightly west of Chicago, Illinois, in 1933.
I don't think I knew that, and I know Aurora.
Oh, you do know Aurora?
I know Aurora, yes.
Very few people know Aurora. It's a very small town. It's in the Fox Valley, and it's, I guess it was the home of the Lyons Metal Company, and they used to make lockers and several other things, but it's basically a residential community, small town.
Yes. Well, it's not very small anymore. I was there just a few years ago because we have good friends from Aurora.
Well, is that right? Yeah.
So
of course, I haven't been there in over half a century, so.
Well, let's go back then. You went to Aurora. After you left Aurora, where did you go?
Well, we moved back and forth from Illinois to New York because my father was a CPA, so we moved to Brooklyn, then we moved back to Western Springs, and then we moved to New Jersey, to West Orange, New Jersey, and then finally moved back again to Wilmette, Illinois, and then finally ended up in Greenwich, Connecticut, where we put our roots down and stayed there.
Where did you finally go to medical school and undergraduate school after all this moving around?
Well, I went to the University of Notre Dame, and then I went to Cornell University Medical College, of course in New York City, and it was quite different than Notre Dame, which is a very strict Catholic boarding school for all men, and then went to New York City to medical school. Total change of climate. Liked it very much.
When did you first decide you wanted to become a physician?
Well, that's probably a little hard to say, but I think it was in the summer of 1946 when I would have been perhaps 13 years old, and I went off to a camp in Michigan called Camp Echo. Returned from camp after the July session, and my mother, who had been a nurse in Chicago, said that one of her nursing classmates called and informed her that there are some jobs open. Now, mind you, I'm 13 years old, but there are jobs open at Evanston Hospital. So John Berry, John Berry, her friend, and I went down there and jobs running the elevator and working in the cafeteria. And I was in there with my Camp Echo shirt on as a 13-year-old boy, very proud of where I had just been. And along came this intern. And now, mind you, we were at a time when the war was just over 1 year, and there were no males around. And this particular intern, I think, judging by the thickness of his glasses, clearly couldn't have been in the military. And so he said, "Did you go to Camp Echo?" And I said, "Oh, yeah, I went to Camp Echo." He said, "Well, we've got some of your guys upstairs." And it turns out that they had a polio epidemic in August of 1946, and about 8 or 10 of the kids from our camp were upstairs in the polio epidemic. And I think that whole situation affected me very greatly. I was around medical people at the time, but I was pretty convinced from that age on that I was going to be a physician, one way or another.
Once you got into medical school, when did you make a decision to become an obstetrician?
Well, that was pretty easy. I was doing some research at Bellevue, and the service that was doing neurosurgery was not very well supervised, and I was doing calorics, trying to look at the stimuli on the middle ear and trying to see if there could be some method of detecting silent brain tumors. And during this time, I had so many bad experiences when some of our neurologic patients went over to the neurosurgical side, and I finally just got very soured on the idea of neurology. And about that time, my sister, my older sister, ended up with her first baby with a rather severe thrombophlebitis and ended up in the New York hospital, Cornell Medical Center, anticoagulated for 3 months. And I'd go in to see her, and I was pretty concerned about the lack of knowledge and the lack of help that there was for pregnancy problems at that time. And I got very interested in OB at that time, and I think I never wavered from then on.
Where did you take your residency?
Right at New York Hospital. I started out at Bellevue with an internship on internal medicine. That included going to Sloan Kettering Memorial for 4 months of oncology. And then I was at New York Hospital for the 3 years.
During the time that you were there, who was the head of the department?
R. Gordon Douglas, a very excellent clinician, superb surgeon, definitely our boss, and we all did things exactly the same way at Cornell, and that was R. Gordon Douglas's way, and I think it was very good training. It was certainly, we all really felt like we had a master there teaching us what to do.
Well, I think he's one of the giants of our specialty.
Yeah, I agree. I definitely agree.
When you finished your residency, what were your plans then?
By the time I finished my residency, I was already pretty committed to doing research, and I wanted to remain an OB/GYN with a practice, but also do research. At this time, I had decided I wanted to do research on the RH problem, or the rhesus problem. And indeed, by the year of graduation, I was able to get a Health Research Council of the City of New York research grant, which, you know, $88,000 in the scheme of things doesn't sound like a lot of money today, but I can assure you that was a huge opportunity for me because I had my own laboratory and my own technician, and I was basically a first-year attending.
Yeah. During this time, you've been credited with being the major discoverer of ROGAM and the use of ROGAM. What allowed you to begin to take this type of approach?
Well, I think I'm going to have to correct that a little bit, but I will let this unfold a little bit. What I got the Health Research Council award for was to study the mechanisms of RH immunization. How did somebody become immunized? Did they have a blood growing across at the time of delivery? Did they have increased fetal blood getting into the maternal circulation at the time of removal of the placenta? What role did spontaneous abortion or induced abortion? What role was labor and delivery itself in this whole process? So I was working very diligently on mechanisms of how they got immunized, and just about the same time, my colleagues up at Columbia, Vincent Freda and John Gorman and Bill Pollack, who was at Ortho, had the idea of giving RH immune globulin postpartum. And indeed, I collaborated with them from the beginning, and they were the first to use it. And I think that a hospital in California was a second. There was a pathologist out there that was very interested in using it, and we were the third. And then finally, the group grew to about 12 people. But I can remember these days very dramatically because a guard would come from ortho to deliver the RH immune globulin, and I'd say, you know, how much does this cost? The guy would say, I don't know, but I know it's insured for $10,000. Well, that was a quarter of my grant at that time, and I thought this was pretty important stuff that we had. But it was actually the Columbia group that really got this the idea and got it going, and I was obviously part of the momentum in this, and certainly one of the major test sites. But these were exciting times.
But you were also the one that brought it really to the forefront for OBGYN.
Well, yeah, I
Your
think
paper on this was one that was very well received.
Well, I think that's true. I mean, I used to always have kind of a running competition with Vince and Freda at Columbia. And remember, in these days, Cornell University and Columbia didn't even talk to each other, even though they were on the same island. And our collaborations were the only collaborations that I know of between the two institutions. And I think that I started writing a great deal about how you got immunized and what RH immune globulin would do to prevent this. And then I wrote a book on it, and I think that was part of what promulgated the idea at this time.
Well, as the father of an RH negative daughter, I'm very appreciative of the work you did.
Well, I'm very happy it turned out the way it did, because that was a very bad disease.
Now, you left Cornell. Where did you go next?
Then I went down to the University of Louisville in Louisville, Kentucky, and I went down there in 1972, April Fool's Day, if that has anything to do with my prospects for doing well down there. And I remained there for 8 years, and it was a very, very good department. We were able to do a great deal of research. At this time, I received the second real-time ultrasound ever developed, so we were sitting there in Louisville, Kentucky with wanting to do intrauterine transfusions and fetal transfusions and many, many amniocenteses. And now we had this real-time ultrasound, which made everything considerably easier, albeit not very easy yet, because the quality of the picture still left a little to be desired. But for the first time, you could actually watch the fetal heartbeat or fetal breathing or fetal movement. And obviously, if you were trying to do fetal surgery of any sort, you needed some sort of dynamic imaging.
Now, after Louisville?
Well, interestingly enough, on April Fool's Day, exactly 8 years later, I went to Georgetown University. So now I was established in Washington, D.C., and that's where I've been ever since. And I think it was a very good move. I really enjoyed living in Washington, D.C., and had a very good opportunity to do what I wanted to in obstetrical research.
And what was your main research period during the time at Georgetown?
Well, actually, I think the most important thing was my sabbatical just before going to Georgetown, and the transition between going from Louisville to Georgetown. Incidentally, I was probably one of the few academics in the country who decided that, you know, if you earned a sabbatical, why not take it? And I did this rather faithfully, and I went over to King's College, and I was there only 6 months, but I was able to do 2 really interesting research projects because I was with Stuart Campbell, and he just kind of opened the doors, and I didn't have to do anything else but the research, and to me that was very easy. And the first project we did was to look at fetal femur lengths. Well, today this sounds rather, prosaic and easy, but they had never really been identified on ultrasound. And I had a new Kretz, state-of-the-art, with a kind of a spinner rotator transducer. And we had many patients come through, and we would follow them serially, measuring their femur length and correlating it with fetal growth. And that ended up with a very nice research project because it fit into both dating a pregnancy or determining gestational age, as well as into trying to detect intrauterine growth restriction, which was another interest of mine. But I think the project that I had most fun with was that we had heard that a physician had already seen ovarian follicles at the time of ovulation, and said that this was, of course, when you ovulated. Well, Stuart and I kind of put our heads together on this one, and we said, what really is needed is proof that this is ovulation. So we happen to have handy a teammate who was very good on doing the urinary analytes, showing whether ovulation had occurred, and so we were basically looking at estrogen and progesterone excretion in the urine. And we would get these patients and follow them serially until they ovulated, and then watch the corpus luteum and correlate it with our findings on the urine. And we were able to detect the timing of ovulation. A little bit far afield of what I was used to doing, but I was also very intrigued by ovulation and the prospects for infertility. One thing that was very funny, though, was that when we were trying to get volunteers for this, I first went to the institutional review board. Well, that is to say, I met the person who was on the institutional review board in the hall, and told them what we wanted to do, and now I only had 5 months to do it, and so forth. And they were very, very accommodating. The only person that wasn't accommodating was the directress of nurses, who found me and said, "Are you the American that's going to be doing all these studies on our nurses here? I don't want you doing them on the nurses." I said, "Well, I'll tell you what we'll do. We won't go out and try to recruit the nurses, but if somebody comes in and wants to participate, we'll let them participate." Well, we ended up mainly with nurses in this program, and we followed them serially till they ovulated. And we had a very good study, and I think we won the research prize that year in the ACOG annual clinical meeting, which I was very proud of.
Matter of fact, I believe that particular research is still considered one of the groundbreaking changes in reproductive endocrinology. It's the first time it was done.
I think the funny part of it, Ralph, is that my son was at my son is a reproductive endocrinologist, was at a meeting the other day, like a year ago, and somebody said, well, the speaker said, well, the 5 most important or the 6 most important studies that went into to IVF were the following, and he mentions this study, and of course my son almost falls off the chair because he didn't think that his father really had done anything in that area, but it was really kind of fun, and I didn't do more in that area, but I thought that was great introduction to Georgetown. And so then I was ensconced in Georgetown, and I would say there we did mainly intrauterine transfusions. We did them for the whole area, and we were pretty successful with it. And of course, there were changes all the time in the techniques, and I think we made some nice contributions to it. By this time, of course, many universities were involved in this.
What is your current position at Georgetown today?
My current position now is professor and chairman emeritus, and I don't have a private practice. I still do ultrasound over there, and I am in the Division of Maternal Fetal Medicine, and I help out with teaching and have students, and still have a couple of research project protocols that are open over there. But I'm spending an awful lot of my time over at the Green Journal now. So I would say, obviously the bulk of my time is over there.
Yes, as a matter of fact, now that you mention it, you are the associate editor of the Green Journal. Why did you take a position at the Green Journal?
That's a funny story. I'm actually deputy editor, but I don't think names mean that much anyway. But one day, I got a phone call from Jim Scott, and he said, I've just been appointed to succeed Roy Pitkin running the Green Journal, and I'd really like to have you come over and be the deputy editor and work with me and try and develop this into maybe a little more clinically oriented journal, so that we can really tell people what the best research is, but also best methods of practice. And I said, well, Jim, I'm in kind of a strange position because I've just signed a contract I'm second year into a 5-year contract with Contemporary OBGYN. And he said, well, why don't you see if you can get out of that? Well, I think this was probably my 27th year as editor of Contemporary OBGYN, and I had planned eventually not to stay with him forever. And I found Charlie Lockwood, and I said, Charlie, I think you would be an excellent editor of Contemporary OBGYN. I went to the publisher and said, I'd really like to be let go on this contract, and they said, could we have a little bit to think about it, and then finally called me and said, we'll do it. And of course, Charlie just stepped right in and did a superb job, and in many respects, I think it was probably a good change so that they had a fresh approach. But I was delighted to start with Jim and Kathy Spong on the Green Journal, because I find that very exciting, and we've got a superb audience, and I think we really affect the way medicine is delivered.
I think you and Jim have raised the journal to probably the most important journal in our specialty in the world.
Yeah, I think that's possibly true.
I think it's very true, my opinion.
You're right.
Let me ask you another question. I noticed the other day you were down in our history area looking at the Chamberlain forceps. What was your interest in that?
I just go down there every once in a while and ask Deborah Scarborough if I could just take those out and stroke them a little bit and get a little inspiration. I share one of your interests, which is a history of medicine, and on my first sabbatical to London some 27 years ago, I saw the Chamberlain forceps, and I saw a book about the Chamberlains, and I got very fascinated with the story of a family that could invent something that was the first thing in history that ever changed the course of a delivery. Remember, cesarean sections were yet 3 centuries off, and antibiotics and blood transfusions were probably 4 centuries off. But here is this family in 1595 that invented obstetrical forceps that could end, let's say, a semi-obstructed labor or prolonged labor, and save both the baby and the mother without any problem to the baby, or in most cases. The fascinating thing was not just that they had discovered this in 1595 or 6 or whichever it was, but then they proceeded to keep it a secret for 130 years. And it became a family secret at the same time that this family had multiple patents on various things, like sailboats that could sail within 1 or 2 points of the wind, and a new way of writing or speaking, which is phonetic. They had many patents, and yet they chose to keep this a secret. And why they did it, you're just going to have to read my book to find out why they kept it a secret for this number of years. And I'll be handing you a copy of that book very soon, Ralph.
Well, I'm looking forward to it, because obviously we do share a big interest. Let me just ask you one final thing. What do you see the future of our specialty? You've been around a while. You've gone through some of the major changes in our specialty. What do you see the future?
Well, I think the future is going to be defined by the workforce. And I think the future is pretty clearly going to go into allowing these highly trained professionals who have many years of education and training and superb skills. Delivering a baby still takes superb skills. Cesareans take superb skills. But I think these people are eventually going to be able to choose how they want to contribute their skills to this area. In other words, I don't think that we're going to see people follow the tradition that you grew up and you graduated from your residency program, you went out and started a practice and you did obstetrics, you did all the surgery that came your way, which was very little, but you did more and more obstetrics and office gynecology, and then you got busier in gynecology and so forth. I think we're going to see the specialty compartmentalize a little bit from the standpoint of giving choices to people on what they want to do. I mean, could somebody be very valuable just working the labor and delivery floor or just working in the OR? Absolutely. It's done in other countries, and it's not necessarily a throwback to say, oh, well, eventually we'll have people that just do the surgery and people that just do the office gynecology, finding the patients to be operated on. I think we're going to see this. But at the same time, because our country is so vast and varied, we'll always see the traditional format of starting out in OB and office gynecology and expanding until there's a time when you want to decrease the OB and increasing now into the GYN. I think we're going to probably have a lot of changes from the standpoint of a little finer honing on what tests we do. I think there'll be better tests. There may be cheaper tests. Heavens only knows we can't go in the directions we're going now. And so if somebody has a pain and the next thing you know they've got an MRI and so forth, I mean, I think we've got to start having a little more sense on what tests we use and how we use them. But I think the future's extremely bright because there are new things all the time that are making our specialty better.
Well, John, I can't thank you enough for coming to the interview. It's been a pleasure to talk to you.
Thank you very much,
we
Ralph.
go back together a long, long way.
A long way, Ralph. Thank you.
Thank you.